So now we come to another very important session. Now, we've been talking about so many medications during COVID and without COVID and other things. And gliptins have been important medications right from the beginning. They have been launched. But then there has been certain changes in our prescriptions during the COVID time. And for these, we will be having another very important person to talk about the toolbox for using gliptins. This is no other person than a very well-known speaker from Rajasthan. We have Arvind Gupta. I know he has a quality of explaining things so wonderfully. So I invite Dr. Arvind Gupta. He's a senior consultant physician, diabetes, obesity, and metabolic disorders at Mahavir Jaipuria Rajasthan Hospital, Jaipur. Interestingly, he has more than 75 research publications in national and international journals, and I can vouch some of them are wonderful papers. Fellowship for various organizations, not to name because there is a long list of them. A medical referee and member of various organizations and won many national and international awards. So with this introduction, because the time is constraints are there always there in our conferences, I will not do any elaborate talking before that. Over to Dr. Arvind Gupta for the new normal toolbox for using gliptins. Yes, I am able to see your slides, and with me, Dr. Bhushan Hathi is the chairperson with me, and Dr. Deepak Achawa is the moderator. We are able to see your slides, sir. Please go ahead.
I don't see my slides now. Yeah. Thank you, Dr. Meenawasar, for giving me this opportunity to interact with all my friends now regarding the very new thing which is known as toolbox, which is very, very famous these days. But now for this context, toolbox I will be using for the gliptins. How the toolbox is used for the gliptins. Thank you very much, and I am really thankful for Dr. Zargar, who has already, set the stage, because he has already given all the details regarding the glucose lowering therapy during the COVID. And then Dr. Ravindra Shukla, he has rightly told about how to choose the right gliptins. But what is the new normal? That is important thing. These are my financial disclosures. And now what is objective today for this particular deliberation is, let us see what is the new normal and the guidance regarding the anti-diabetic therapy, although the stage is already set by Dr. Zargar sir. Then what is the role of gliptins in this particular new normal situations, and let us see how to choose a particular gliptin. So let us see the challenges in the new normal and guidance for the anti-diabetic therapy. Dear friends, we have already experienced bad experience, I can say the worst experience in first 2 waves of COVID, and probably we don't know about the real things about the third wave, but we have to be very careful in next 1.5 months till so many festivals will be there till Diwali. So I think we have to be very careful for the third wave, and let us see the disasters and pandemics. Actually, they pose challenges to us. They have learned so much lessons to all of us. So what are the key challenges for managing type 2 diabetes patients? We have the limited interaction with the patient, definitely with healthcare personals. Then it reduces the access to monitoring. And of course, there are so many infections. Then we have the resource restriction for a chronic disease management. And of course, the stress is, tremendous stress is there for both the patients as well as for the healthcare personals. Now, telemedicine has come to rescue for all of us, dear friends. And this is the real, the help to all of us, whereby the patients can interact very well with the healthcare personals. We can do consultations. Of course, diagnosis is little difficult, but of course, we can support with certain clinical cases to our patients. Let us start with this one particular case. The 40-year-old male with type 2 diabetes for last 5 years, and he has teleconsultation for all of us. Of course, we have already given the lifestyle modification. He does not have any complications, but he is taking metformin and sulfonylureas to the almost maximal doses. But still, if you find the HbA1c is very high, 9.2%, and their blood sugars are very high, I mean both fasting and postprandial blood sugars, and he is overweight or obese type 2 diabetes patients. Now, how to do deal with this type of patient and when he comes to us for the teleconsultation? Dear friends, we know that there is a minimal secondary failure for most of the, drugs except sulfonylureas. We have to have the sick day management to the patient, and then the most important thing, we on teleconsultation we have to give the prescription in such a manner that it should be easy dosage regime. It should not be a very complicated disease, drug regime. And of course, the most important thing, in the era of polypharmacy, there may be a drug-drug interactions. So you have to be very vigilant while the drug-drug interaction with most of the drugs. And the important thing is not only the efficacy of the drugs, but the tolerated. Most of the patients should tolerate these drugs. And when we come to the telemedicine, there are certain limitations for the telemedications because we cannot prescribe so many medications. If you can see here, of course, in diabetes, we have person is already having metformin, sulfonylureas, and for asthmas and all the other things. But we can add fewer drugs like DPP4 inhibitors or the other SGLT2 inhibitors on telemedication. But certain drugs, for instance, anti-cancer drugs, narcotics, codeine, these should not be prescribed on the telemedicine. This is not legal at present. So now this is a challenge for us. We have so many drugs with us for the treatment of management of type 2 diabetes. We have insulin, metformin, GLP-1 receptor agonists, SGLT2 inhibitors, and DPP4 inhibitors. I think this is very important because insulin, once the patient is on insulin, and Dr. Zargar Saab has beautifully stated that if the patient is on insulin and well controlled, please do not stop, but gradually down titrate the dose of insulin as the patient gets stabilized over the time. And once the patient is stabilized, you can down titrate the insulin and you can start with the drugs, oral drugs like metformin. But whenever you are prescribing metformin during the COVID or during the infections, please take care of hydration of the patient. Otherwise, the patient may go into the renal, the diabetic ketoacidosis. As far as SGLT2 inhibitors are concerned, recent studies, DARE 19 and all other studies have clearly showed that they can be continued during the COVID period. But again, the hydration part has to be taken care of whenever we prescribe the SGLT2 inhibitors. Of course, renal functions should be monitored on a very regular basis. GLP-1 receptor agonists, dear friends, we can use during this period, but again, the hydration point of view, nausea and vomiting is very common to start with when we start the GLP-1 receptor agonist, and then of course fluid intake and other things should be taken care of. But the cost is very high, so I don't think most of the people are using a GLP-1 receptor. Now we rescue for us is the DPP4 inhibitors. Nowadays we can use DPP4, they are well tolerated drugs. So let us see in this particular patient what we have seen. I think DPP4 inhibitors have come to the rescue for all of us. This is another case. This is a lady, 45 years lady, with HbA1c is very high, with osmotic symptoms are already there. She is normal weight, I can say, but in she has already lost her husband in the last COVID, and she says that please, I can't take injection. Now this is what to do with this very high HbA1c. Now if we prescribe insulin, maybe patient will not come to you because she is not agreeing with the insulin. And of course, the adherence to the insulin, we know that it is until unless we motivate our patients do not adhere to insulin for a longer period of time. So now we have several options. Can we continue with the metformin? Can we continue with the DPP-4 inhibitor? Can we add sulfonylureas? Or we can combine 2 or 3 drugs. Key advantages of gliptins in this particular case, if you can see the efficacy, we know that gliptins are efficacious drugs across, where irrespective of whether the patient is having renal health or the age, gender, etc. It is irrespective. They are effective. Another easy dosage, once or twice a day timing, and the patient gets, the response very well. They are very well tolerated, very mild or minimal side effects, I can say, and minimal secondary failure. They are actually, there are so many evidences which says that they can be used for 5-6 years with the same efficacy when you start with the gliptins. If you see, this is one study whereby the sitagliptin is being used as compared to all other anti-diabetic drugs, and you can see the efficacy is still there with the gliptins as compared to SGLT2 inhibitors or even sulfonylureas. So DPP-4 inhibitors are effective without doubt, and if you compare the gliptins with the metformin, sulfonylurea, pioglitazone, or even alpha glucosidase inhibitors like glucovoglibose, you can find even with the metformin, I think it is almost same. It is rather 2.2% as compared to 1.9% reduction in HbA1c. With sulfonylureas, almost effective, and you know the Carmelina study and other studies which has shown the efficacy of gliptins as compared to the even sulfonylureas. Pioglitazone, comparable, even alpha glucosidase is much better. Gliptins are much better than alpha glucosidase inhibitors. And if you see the long-term efficacy of the drug, it is still maintained over 52 weeks or 24 weeks. And these all studies are published, which says that even if you compare with the SGLT2 inhibitors, the gliptins maintains the efficacy for a longer period of time. If you see the comparative effectiveness with the other head-to-head comparison with the gliptins, I think my general statement is most of the gliptins are effective, and they are modestly effective as far as the glycosylated hemoglobin reduction is concerned. But when you combine these gliptins with metformin or sulfonylureas or SGLT2 inhibitors, their effectiveness increases like anything. So dear friends, we have seen the evidence that they are very, very effective and long-term effective. Let us see the doses regime. If you see all the gliptins, most of the gliptins can be used once a day, except the vildagliptin, which should be used twice a day. We don't know about the recent vildagliptin, which is 100 milligrams. I don't know about the pharmacokinetics and pharmacodynamics of that particular vildagliptin, which is used once a day. But I think the evidence is that still we have to use twice a day vildagliptin. So as far as the doses regime is concerned, this is very simplified. So dear friends, third thing is important, the drug-drug interactions. So it is not that because we are living in a polypharmacy era. So if you see here, all the gliptins are safe as far as drug-drug interaction is concerned, except the sexagliptin, which cannot be used when the patient is concomitantly receiving the ketoconazole or diltiazem because of cytochrome P34A inhibitor. So there is a drug-drug interaction with sexagliptin. Otherwise, and when the patient is having severe hepatobiliary, then I think linagliptin cannot be used into severe hepatobiliary decompensation. Otherwise, in a compensated, Dr. Ravinder Shukla has clearly told most of the gliptins can be given. Now, the other thing is a toleration. If the patient tolerates, I think most of the gliptins can be tolerated very well. I have not seen a severe side effect whereby the patient we have to stop the DPP-4 inhibitors in most of the patients. But if you see here, the as compared to sulfonylureas or thiazolidinediols, I think the DPP-4 inhibitors can be tolerated very well. Now, how to choose the gliptins, which gliptin is effective or which is not effective? Just this is one case where 64-year male type 2 diabetes patient again came to us for the teleconsultation during the new normal, and only 2 years duration of diabetes, and he's only on metformin monotherapies. He's having additional, because he's hypertensive and dyslipidemia, so he's already receiving lisinopril, hydrochlorothiazide, and atorvastatin. If you see the blood pressure, I mean the body mass index and all these things, patient is having high HbA1c here, but little bit on the higher ALT and AST. SGOT-PT is little bit raised. However, their renal functions are normal. Now, how to start with the DPP-4 inhibitors? That is the point, how to choose here. Again, the efficacy part. And we have seen Dr. Ravinder Shukla has clearly stated that most of the gliptins actually have the 24 hours DPP-4 inhibitors is to the tune of around 85 to 75 to 90%. Except the vildagliptin. Now vildagliptin, which is twice a day, I think it is equal to all the gliptins. So as far as the DPP-4 inhibitor is concerned, of course sitagliptin is little scores over the other gliptins, but I think they are almost having more than 75% or 85% inhibition of 24 hours. Now, if you see head-to-head clinical trials with all the gliptins here, dear friends, I think I don't see the modest efficacy of all the gliptins to the tune. If you see here, whether it's a vildagliptin, sexagliptin, or linagliptin or other gliptins, there is a modest, reduction in the HbA1c. Whether it is a durable, dear friend, this is for 7 years. This is already published study again, and this study clearly showed us that a gliptin can be effective for 7 years with the same efficacy. So this is actually reassuring all of us that we can use DPP-4 inhibitors for a longer period of time. As far as tolerability is concerned and the CV side effects are concerned, I can say all the gliptins are cardiovascular neutral, whether it is Sita, Vilda, Lina, or other gliptins. Now, as far as only the sexagliptin in the sabertimib 53, whereby little bit increase in the hospitalization for heart failure with the sexagliptin, but as far as the sitagliptin is concerned and other gliptins are concerned, they are cardiovascular neutral. Hence, we can safely give to all the gliptins to all our cardiovascular disease patients with diabetes. And so cardiovascular safety is maintained, whether the patient is less than 65 or more than 65, whether the TICOS, Carmelin, and all other studies clearly said that gliptins are safe. Whether the CKD and non-CKD, yes, here the only, the thing is that linagliptin can be given to all the eGFR range up till end stage renal disease and during dialysis. But the only thing is other gliptins, the doses has to be reduced when the eGFR going below 45 or below 30. So that is the only situation. And for all HbA1c subgroups, whether very high HbA1c or a lower HbA1c, the DPP-4 inhibitors are going to stay and going to be very effective. As far as the key safety and tolerability is concerned, if you see, except the QTc prolongation, whereby few gliptins can be safely given, except the teneligliptin, which has shown, cannot be given if the patient is already having QTc prolongation or having arrhythmias. In those cases, teneligliptin should not be given. Otherwise, the other gliptins are okay. As far as Sita, Vilda, and linagliptin is concerned, there is no concern with the QTc prolongation. As far as other safety in the CKD, we have already discussed it. So, dear friends, if I can summarize, during the new normal situation, whereby we are actually had limitations by having the physical interaction with the patients, the consideration of the anti-diabetic agents are very, very important. Hereby, I can say gliptins are very, very safe options for all of us during this particular period. Safely prescribe gliptins to most of the particular period. You can safely prescribe gliptins. Few indications or contraindication, you have to optimally use those patients. So when choosing a gliptin, it is important to employ a careful selection. And of course, we are living in the highly individualized era. So whenever we are, this is art of managing type 2 diabetes. The patients of type 2 diabetes needs highly personalized and individualized care. Hence, your selection of the anti-diabetic drugs, especially in gliptins, are very, very important. And I have given you all the aspects of gliptins during my last deliberation. Thank you very much, and I'm available for the question and answer. Thank you. How can I
Thank you
stop?
very much, Arvind. No, you don't have to stop. Just a moment. So we have had very good discussion on DP4 inhibitors, and I am sure the experience which you have shared will be of great utility. Now, again, there are always questions about comparing DP4 inhibitors with other drugs. Barring volume depletion and certain chances of ketoacidosis, how do you score DP4 inhibitors as compared to SGLT2 inhibitors, which are equally effective and have a shade better uh, indications in about, say, in heart failure and things like that?
Yeah, I think the only I have given the clue during my deliberation, the DARE 19 study, which is very recently published, which has shown that SGLT2 inhibitors are also can be continued during the COVID infections, except during when the patient is in ICU. Sir, we never use anti-diabetic drugs during the ICU. It is the basal bolus therapy. Dr. Jargar has clearly stated. Once the patient is stabilized and shifted from ICU to the ward, and here now we down titrate the dose, and then we start gradually the oral diabetic drugs. Hereby, we start with the DPP4 inhibitors as the first thing, and then the metformin if patient's hydration is very much good. And the third thing is that when patient is little overweight, and even patient is having little bit of concern with the heart failure, in that case, now we can start the SGLT2 inhibitors, and even we can continue the patient same drugs, DPP4 inhibitors plus SGLT2 inhibitors, even post discharge. So even at the home, patient can take safely these two drugs. But only thing is we have to monitor the hepatic enzymes and the creatinine and eGFR on a very regular basis. I can say 2 to 3 weeks, every 2 to 3 weeks initially. And once the patient is completely stabilized, then it will be a routine things, but we are monitor 3 months down the line. So this is how, but the SGLT2 inhibitors are still, and DARE 19 has given the clear stated that yes, you can continue all the SGLT2 inhibitors during the COVID infections.
How quickly do you consider that if a patient is coming out from ICU, how quickly he should be changed from insulin to an oral medication?
So within, we have to wait for 24 hours.
How quickly
24 hours minimum
if
for
he's not
the,
on steroid later on.
Yeah. So 24 hours is the real period when we are shifting from ICU to the, when the patient is completely stabilized, the fluctuation of blood sugar is not there, and basal bolus, I mean, the dose should not be more than 40 units per day, and I think that is the right time. And patient's vitals are absolutely normal. I think we can shift from ICU to ward. Now, here is the period when we should down titrate the insulin. I think it takes 24 hours again to stabilize and to see whether patient is doing better in the ward. Then we can gradually down titrate. Initially, we have to down titrate the basal, I mean the bolus insulin cut down the bolus insulin, start the DPP-4 inhibitors once a day. Then if patient is well, then we can even start the metformin or the SGLT2 inhibitors during the stabilization period. But the only thing is the hydration, creatinine, and hepatic enzymes are okay. Patient should not be on a very high doses of steroids. Now, if a patient is having tapering doses of steroid, in that case, we can continue DPP-4 inhibitors, basal insulin, SGLT2 inhibitors, and even metformin.
So this is a very important question answered. What I understand is that in fact it is difficult to reduce insulin immediately. So it will be sensible if the patient is stabilized and comes into the ward after ICU. We add a DP4 inhibitor and continue little doses of insulin, gradually reduce, and then the normal dose of oral medication can be started as it was before. This is what I understand you have been able to say. So this is a very
Yes, sir.
important question. I think Arvind has answered it very wonderfully. So thank you very much, sir. Thank you very much for giving us time. And we have been really enlightened with what you have said. The some of part of course has been revised, but then you have reinforced what has been told before, and this is what is going to help our clinicians. With this, we come
Thank
to
you.
another
Thank
very,
you.
very important session,